Record to. All right, so hello everyone. This is really a great honor today to welcome Professor Kendler. As you all know already, Professor Kendler is one of the most prominent and highest cited psychiatry researchers in the world. I will not mention again his age index. I will just say that Professor Kendler is Banks Distinguished Professor of Psychiatry, Professor of Human Genetics, and Director of the Virginia Institute of Psychiatric and Behavioral Genetics at the Virginia Commonwealth University in the US. There are two main, very important topics in his research, which are the genetics of psychiatric and substance abuse disorders. Professor Kendler served on the work group that revised the DSM-III, on the task force for DSM-IV, and on the DSM-5 work group for mood disorders. In addition to being one of the most famous and important psychiatrists of our times, Professor Kendler has been extremely interested in philosophical issues in psychiatry. He has had many collaborations with professional philosophers. I want to strongly recommend the volume Toward a Philosophical Approach to Psychiatry, the writings of Kenneth S. that was published in 2019, and this is the putting together of very important papers in philosophy of psychiatry written by Professor Kendler. He also wrote a paper with Zaka and Craver entitled What Kinds of Things Are Psychiatric Disorders? And in addition, one of the very recent collaborations of Professor Kendler with a professional philosopher is a collaboration with the outstanding philosopher and philosopher of science, Jim Woodward. And Jim very kindly agreed this morning to join us for this Zoom. So I really want to thank you again, Jim, for that. And I very much recommend their several papers together, but the one we read for today is called Top-Down Causation in Psychiatric Disorders, a clinical philosophical inquiry, and was published in 2021. And I want to mention one last thing, which is that the first time I met Professor Kendler was at the Philosophy in Biology and Medicine meeting in Pittsburgh back in November 2022. And it was absolutely fantastic to have there both Ken Kendler and Jim Woodward. And in the talk they gave together, not only did they explain very well the paper I just mentioned, but they also explained how they came to collaborate together. And if I remember correctly, it all started with a nice dinner and Ken Kendler suggesting that maybe they could collaborate on causality and different topics in psychiatry. And that led to this paper. It was very interesting to see a sort of real life collaboration between a psychiatrist and a philosopher explained by these two voices in Pittsburgh. So with that, I really want to thank you once again, Ken, for agreeing to give this talk. And I want to mention that the talk will be a conversation. So Professor Kendler will explain how it will work. So thank you again, and the floor is yours.
Thank you, Thomas. So I've been looking forward to this discussion. What I would like to do is to take 3 or 4 what I would describe as kind of leading central philosophical topics in psychiatry, spend 10 or 15 minutes giving you my broad view, and then open things up for discussion. And I think that will probably take most of the time. I have a few other ideas in my pocket if we have some additional time, but that at least will be the approach. I thought I also ought to begin by elaborating a bit on my background and my rather unusual road to philosophy. I was a religious studies major in college. My senior thesis was on the ancient Hebrew prophets of the Hebrew Bible. I went to Stanford School of Medicine, a very academic place, and sort of struggled quite a bit with the intensity of the information that I was required to consume on a daily basis in medical school. It wasn't a hard decision for me to go into psychiatry. I trained at Yale at a time period where psychoanalysis was beginning to fade. and biological psychiatry, the very naive neurochemical version of that, in which one could attribute all major psychiatric disorders to abnormalities in either norepinephrine or dopamine or serotonin, was coming on board. It was a very interesting reflection because thinking back on that for 10 or 15 years later, no one sat down with me or with our highly selected group of residents and explained how the whole thing might fit together. We had these sort of isolated classes. I had the psychoanalysts telling me that what the biological psychiatrists were saying was bullshit and they didn't know how to talk to patients. And the biological psychiatrists were saying that the psychoanalysts were just making things up and this wasn't real science. It was a very confusing time to kind of understand a structure of psychiatry. I launched into an early career in neurochemistry. Sort of 3 or 4 years in, I discovered I didn't think any of this was going to work. And 40 years later, that was basically right. All these neurochemical theories had really petered out, and thought that genetics was more interesting. And so I was working hard. I have been in this field now for more than 40 years, going through all the various paradigms up to the latest large-scale studies of genome-wide association, et cetera. I don't think any of that topic is sort of critical. Something happened to me in sort of the early 1990s, so I was then in my mid 40s, and it began with this funny realization. I, at that point, was doing large-scale twin studies, sort of comparing identical twins and fraternal twins, and trying to make conclusions about their similarity for constructs like depression, anxiety disorders, panic, eating disorders. And it was the simple insight, which was that at some fundamental point, I was trying to draw a path from what is going on in a human genome to what is going on in the subjective experience of human beings, like anxiety or sadness. And you would have thought that that would have been kind of commonplace, but it actually hit me like a proverbial ton of bricks, that I was actually scientifically astride the mind-body problem, thinking about somatic features and thinking about translating. That led to my intense dive into John Searles, and I was reading and thinking about the mind-body problem to the point that my wife told me at the dinner table she didn't want to hear any more of the stories that I was saying about the person who lived in the room without color vision and what happened when I stepped out and the Chinese room problem, et cetera, et cetera. Little things happened along the way. I was on the editorial board of the American Journal of Psychiatry, a leading journal. I was talking at lunch about how much I had been reading in this topic, and the then editor, Nancy Andreessen, said, "I've been trying to get that goddamn John Searle to write an editorial about the mind-body problem for our journal for years, and he's never answered and reliable." And then two of my colleagues started pointing at him. "Ken's been reading about this a lot. Why don't you write it?" And I look at them around saying, "I've been volunteered." So that was my first venture into trying to write something philosophical for the psychiatric community. And it was quite interesting because I was trying to connect up my scientific, well-developed image to thinking about these broader conceptual areas. And I actually found it quite thrilling. The next major event was being invited to go to the Center for the Advanced Study of the Behavioral Sciences in 2003, and I got a sabbatical. And I met a Glasgow-born, Oxford-trained philosopher, John Campbell, there, and we hit it off big time. And so we would spend many lunches talking back and forth about a range of problems. And it turned out, although I was working on a book then, my intellectual fire got lit, and I wrote my sort of first serious philosophical essay, trying to develop, again published in the American Journal of Psychiatry, on a conceptual framework for psychiatry. So since that time, I've had the great pleasure of working with a range of, as you say, professional philosophers. I've also established a collaboration with Josef Parnas, who is a phenomenologic psychiatrist working in Denmark, and we've now put on 6 psychiatry philosophy conferences in which it's given me an opportunity to meet people. And this has become a significant part of my venture. I think I always had it in me, but it took some lighting to see how important in understanding the scientific work I do, the philosophy is important. And one final theme before I get into topics. I've largely given up on the ontological kind of murkwood forest of the mind-body problem. I've read and I've read and I've read, and trying to get traction on those issues in psychiatry has been much more difficult. So much of my reading has been in the philosophy of science. And there, the relevance of those to psychiatric topics is much clearer, I would say. So I think that's sort of a general background to see. One more point was implied by Thomas. I've been centrally involved in the DSM process from the mid 1980s up until now, and so I've been in the beast. I've seen it work. I've seen it develop. I particularly play this key role in DSM-5 as being called in by the American Psychiatric Association to kind of rescue the mess that DSM-5 was in, chairing the scientific review committee, and so if we have time, and one of my topics will be to talk about the conceptual and philosophical issues that arises in psychiatric nosology. So that's an introduction basically to my background. So I want to begin where I think the logical place always is here, which is the ontology of psychiatric disorders. That is, what kinds of things are these? If you open up a DSM book, you have terms like major depressive disorder, panic disorder, autism spectrum disorder, schizophrenia. And I think that that's kind of foundational to many of the other topics that you will examine. I will share with you the framework that I have largely worked through, and then give you my major conclusions about where things stand, and then I'll stop for a time to sort of break for discussion. So although there's many different terms in this world, I've really settled on three. One is a kind of realistic model, natural kind, it's sometimes used for psychiatric disorders. And roughly what that means, and I've tried to explain, is that means that these conditions are mind independent. That is, that they exist in some way independent of human existence, such that there should be a constant, at least in our world, if not in the universe entirely, with concepts like schizophrenia, autism, major depression. There are people who would defend that. And had you asked me when I was 33 and running a dopamine neuropharmacology laboratory, I would have probably casually, having given it very little thought, said, oh yeah, these are real things, whatever that means overall. Now, on reflection, that's an absurd hypothesis, at least in subforms. So if we look at natural kinds in science, one model that always has been a useful didactic one for me is the periodic table. And categories of oxygen and nitrogen and sulfur and helium are real categories in some crucial ways that clearly do not apply to psychiatric conditions. First, importantly, they exist anywhere in the universe, right? It's nothing to do with man or mankind. Second, their boundaries are unambiguous. You can never confuse, if you have proper equipment, an atom of oxygen with nitrogen. They have all these different properties. And third, they have essences, which are considered to be one important feature of natural kinds. So once you know the number of protons in the nucleus, and therefore the number of electrons in the cloud around the atom, almost all the combinatorial properties of that atom is known. Now, it's true that there are different numbers of neutrons and you can have different atomic weights, so-called isotopes, but that's a fairly trivial feature. So I use that at least as a clear paradigm, which in no plausible way could psychiatric disorders ever be considered natural kinds defined in that manner. Now, if that's on the far left of our spectrum, if we move into the right somewhat, we then get to a category that's obviously has many more parallels, which is biological species. Now, biological species share some important similarities that, of course, elements of the periodic table don't. First, they got fuzzy boundaries, right? So, if you've got two populations, of the grouse, some bird, there's going to be some hybridization around the corners. And as you go north, the animal's going to get a little fatter and they'll be skinnier when you go southward. And those are kind of well understood variations. So that's an important similarity. Second, they have no single a single property or essence. There is no thing that you can classify that makes a giraffe, and a lion, and a porpoise. Interestingly, those of you that have followed this field, once we started sequencing the chimpanzee genome, there were all these people rushing out to find the human gene, as if there was be a single gene variation in chimpanzees that made us human. And as you can imagine, there are hundreds and probably hundreds of thousands of variations that occur. So there is some plausibility to argue, if you want to take a natural kind approach, that psychiatric disorders might be the species flavor of natural kinds, but not the chemical theories of natural kinds. Now let's move, if we go to what I would regard as a middle position, and this is roughly often described as pragmatic kinds. And it's very related to the philosophy of science idea of instrumentalism. So there's this deep debate within, let's say, physics about, is an electron, is a meter, is the speed of light real? Or we just use those things as tools to help us understand and predict the world. If you were to ask many psychiatrists, especially those that are not philosophically minded, what good is a diagnosis of schizophrenia? They will give you a kind of pragmatic answer. Well, once if you tell me I have a 32-year-old patient with paranoid schizophrenia who's partially controlled on 10 milligrams of haloperidol and a referral note, that gives me a whole lot of information. I know a whole bunch about the person. It's very succinct. It's pretty useful. When we organized the Psychiatric Genomic Consortium, this huge effort throughout the world, spending $100 million a year at least to try to find the molecular basis, we classified these by these categories. We have a schizophrenia psychiatric genomic group, a major depression group, an autism spectrum group. Why did we do that? Well, it kind of helps organize this space. It's been sort of useful. And when we try to develop our nosology, which I'll talk about later, it is often based on the practical things that a diagnosis can do. So a good diagnosis for us would do things like predict some biological findings, predict what your brain might look like on MRI, predict what your outcome might be like, predict how you'd respond to psychoactive drugs, predict something about the childhood risk factors, all those features, and that the way to evaluate a good diagnosis is one that takes that perspective. So that's very appealing. That's sort of a common sense view. It's not a philosophically ambitious view. And let me get on to the third, and then I'll come back about where I have been. The third view of psychiatric disorders, which used to be certainly seen as an enemy to psychiatry during the anti-psychiatry movement, is social construction. And that's basically human beings make up categories for all kinds of reasons, including prejudice and bias and social forces, etc. I used to think when I was younger and more naive that that was a terrible and even insulting idea, but actually that's completely silly. For example, I've sat through the DSM processes and the arguments back and forth and the factions, coming back and forth. And if you think that DSM is not partially a sociological phenomenon, you're not living in the real world. There are all kinds of pushes and pulls about what make diagnoses significant. And I was very pleased that Peter Zacher and I had an idea over a conversation, a little bit like I did with Jim. I was reading at a time when even in the New York Times, the fights of the International Astronomical Society about whether Pluto was a real planet or not was common. So Peter and I set out the goal. Let's read. It's not something I knew a lot about. Let's read about how that worked and then go back to what is always regarded as an embarrassment in the history of psychiatry, which is the way that the American Psychiatric Association decided in the early 80s to decide whether homosexuality was a disorder or not was to do a mailed poll. People voted, which is Kind of a crazy idea. Well, you want to know how the Planetary Society decided whether Pluto was or was not a planet? They had a vote. And they had these criteria, just like we have for psychiatry disorders. It has to be in a particular plane. If you're sort of, only 5 or 10 degrees off the plane of the other planets, and it has to sweep all the other satellites in the era. And people stood up and they yelled and screamed, I just got a $15 million grant to study Pluto, and you're now going to call me that it's a dwarf planet and not a real planet? How dare you do that to my research program? Just like things happen in psychiatry. So that was very amusing to me. Shows that psychiatry has this normative scientific process. And there are subtler points to be made, which the best example is PTSD. And this is something I lived through. PTSD, post-traumatic stress disorder, got into DSM-III because of the war in Vietnam and the protest community that veterans came back with bad traumatic experiences and wouldn't get treated at our Veterans Administration Hospital because it wasn't a real disorder. And they appealed to some liberal-leaning psychiatrist, in particular Bob Spitzer, and he got other people to review the evidence, of which there was some. It had been called shell shock in the First World War and combat fatigue, and made it a disorder. So there is a time at which social factors, anti-war movement, sympathy with veterans played a role in official psychiatric nosology. So the idea that we sort of can wash our hands of that and we exist in this pure, kind of platonic range where we never dirty our hand with social factors is really not supportable. Now, that's not the same as people making up psychiatric disorders for social reasons, but they did do that. There is a psychiatric disorder that was published by, and I think it's drapetomania, but I'm not positive. Mania was something that Esquero developed for erotomania and all those other terms, kleptomania. But it was a psychiatric diagnosis which you diagnosed in African Americans when they were slaves that included the delusion that they would be better off when they were free. Right? So that is a psychiatric disorder that is taking, it's antithetical to anything that they believe about psychiatry, but it's trying to label somebody for social purposes. Now, no one takes those diagnoses seriously, but I did live through the 1960s and 1970s when social protesting individuals in the Soviet Union were given a fake diagnosis of sluggish schizophrenia with reformist delusions, was the name of it, and given heavy antipsychotics and stuck in prisons. So it is certainly possible that psychiatry and psychiatric diagnoses can be abused for social principles. So let me now take a step back. I'm doing fine on time. So there's a spectrum of these conditions from a kind of harder, scientific-based, more ambitious view. That's what natural kinds are, where the extremes clearly don't apply. But is there some softer version of that might work? Yeah, possibly. The pragmatists in the world just think about, I want things that work well in my world. They tell me important things, and that's the value. And then the social actions, which I think have some real point, but they're not generating a huge amount of important influences. Now, let me take a small digression. I have borrowed from the evolutionary biologist Gould this lovely, his model of playing the tape of time again. He goes back, to early in the course of evolution and runs through the human evolution and how conditional, how many times if we simulated the world would something like human beings arise? Fascinating question. I had a sort of simpler version of that if we go back to 12,000 years before the Common Era, we were developing agriculture and then eventually cities and then eventually medicine. And then I'm imagining in most evolutions, as medicine divides up into its specialties, you get the eye, you get the liver, he gets the womb, that some specialty will emerge that will be something like psychiatry. And then at some point, those people are going to sit down and write something about listing out their diagnoses. So if we were to do that, let's say 10,000 times, and simulated what those DSMs would be, how consistent would some categories be? It's a very interesting, and I often talk about this, the typical response, and my response is something like schizophrenia would probably show up most of the time. And something like autism Probably. And something a bit like depression might be narrower, maybe panic disorder. But things like borderline personality disorder or narcissistic personality disorder, not very likely. It sort of just came out of a particular psychoanalytic tradition. It's not, it's not very common, etc. So I think that is one fascinating thought experiment to study on these. Now, my final comments here. I have an emotional attachment to the realism because I exist in a biomedical environment where making derogatory comments about psychiatric disorders not being real, in quotes, occurs frequently and is deeply offensive to me. Because if you talk about real equals human suffering, and I've never claimed that philosophically, the amount of aggregate human suffering due to psychiatric disorders compared to myocardial infarction and cancer and lung disease is high because it causes suffering not only in individual people, but in their families. So I'm not willing to surrender the idea that in some sense that is hard to define, psychiatric disorders are real, at least in part because I have to advocate for these disorders on review committees. I've had surgeons say, oh, you can't do a spinal tap. That's too dangerous. That person just has a psychiatric disorder. That's not a real disorder. And I just get all agitated. You know how much suffering these things arise? So that binds me somewhat to realism in some weak way, but certainly I've got another foot in the pragmatism world about what we try to do with diagnoses is just make them good and make them better. So I've drifted over time, certainly away from the more rigorous ones. And I think it's a genuine subject. It's not going to have a definitive answer. But I think this might be a good stopping point just to have a conversation about these broad set of issues. So I'll be quiet.
Thank you. You shouldn't be quiet, but I hope that some people will have some questions and comments. So I guess it's easy. I mean, it's more difficult for the people who are in the big room here in Bordeaux, but for other people, I guess it's easy to just open your microphone and ask your question or make your comment. Maybe just to start, this last point you made, Ken, sounded a little bit surprising to me. The suffering can perfectly be real without any classification having to be defined as real in the sense that you would be realistic towards your own categories. So I was a little bit surprised. Of course, the suffering is real. I perfectly understand that. And I perfectly understand that you have to fight against a different view in your daily life. But why would you think that this would be a good way to make a point in favor of the kind of scientific realism you were talking about natural kinds?
Yeah, I'm not sure it does. So I'm not claiming that I'm rational here, but I don't want to give up hanging on to the idea that in some important way, psychiatric disorders are real, even if they don't make a rigorous philosophical point because of the kind of moral and ethical responsibility I feel towards psychiatric patients. I think
Yeah.
that's what
Okay, that makes very good sense. So I see there's one question or comment in the Bordeaux team room. So
Can you hear us?
yes.
Can you hear me?
Yes.
Okay, great. So me being Jan Peter Constant, I'm a former neuroscientist turned a philosopher. So I want to circle back to the paper that we read, the collective paper with Tim Woodward. And so I really thought it was interesting to hear this comparison about downward and upward causation. And my question would be that I agree with you that Tim Woodward's perspective fits neatly with testing downward causation hypothesis. However, I do have the feeling that many of my former colleagues oftentimes prefer testing upward causation hypothesis with the idea that it's easier to come to a so-called ideal intervention, like lower levels would be easier to intervene on without running the risk of like changing factors that could also give rise to the potential consequence. I would like to hear your comments on that because that's That's something I've been hearing a lot, that downward causation would be dirtier to test in a way.
I was going to treat that topic in a future part of what I'm talking about.
Okay,
So let me just briefly say,
we can also get back to it later.
yeah, one of the most empirically shown treatments in all of psychiatry is cognitive behavioral therapy by Beck. And if that's not a top-down causal feature, I don't know what is. You're sitting in a room and you're auditorily processing the voice of someone pointing out your approach of habits and causing you to self-examine. And it turns out that that does make people better, and it even changes some MRI functions in the brain. So I'm not sure that I would always think, certainly many people are more comfortable with bottom-up approaches. But if you believe, as I do, that mental processes are an essential part of the psychiatric phenomenon, and that we can intervene as we do in life through our real intimate relationships with people, I think ruling out top-down causation because it's messier or less clear is a non-starter.
Okay, thank you. But would you agree that top-down or downward causation would be messier? Because that seems to be widespread belief among biologists.
Messier, that's a pretty
Yeah, and for lack of a better
the interventions. I mean, we now have rule-based, manual-based psychotherapy. Psychoanalysis was way messy, right? I mean, 5 years on the couch, free associations meandering about. CBT, you got a manual, you have stuff to structure. Is that messier than taking a single compound like, fluoxetine and putting it in your brain and then watching this complex process of your synaptic potentials responding and changing over time? I'm not so sure. Messy in a different way, I guess, but I'm not sure messier overall.
Maybe not comparable.
Okay.
Many questions or comments. The first seems to be by James, and then we have Amir on the chat. I will read that. So James Turner first.
Hey, can you hear me okay?
Yes.
Fantastic. So I'm very interested in your comments about you sort of sliding from some kind of maybe light realism to pragmatism, and this seems to be something that seems to be quite widespread. But then when you look in the front of the DSM, it says things like these conditions are supposed to reflect an underlying biological or psychological dysfunction, and that seems to have quite this strong realist scientific flavor to it. I understand dysfunction is also used in a more kind of social context. But when we talk about biological dysfunction, we like to think failure to perform some kind of objective, whether that's like selected effect function or something like that. And I was wondering what your kind of general thoughts on that as a guidebook then are. Should that be removed? Should we be a little bit more humble about these kind of things? Should we sort of stress that there may be these pragmatic elements to it? So yeah, general thoughts on that. Also, I should say I'm a philosopher at Umeå University in Sweden.
Oh, that's a lot. I was involved in trying to work on the definition. It is astounding how difficult a really workable definition of mental illness is. So, in my DSM experiences, you get all kinds of proposals, things like you should make racism a psychiatric disorder, which for anybody with any sense says that's a terrible idea, but explaining why it's a terrible idea is extremely difficult. So these have been kind of rough rule outs, and they're better at ruling out. So it's not social deviance. It's not political stuff. And I think the rough intuition, and this is, I can spend more time on this, that something has to have gone wrong in the way you socially function, your mind functions, or your brain to call something a disorder. It is a relevant issue. Example, the proportion of people that have things like spider, snake, rat fears or phobias is large. And if someone presents to you for some odd reason, and she says, oh yes, I've seen spiders in my basement, and I don't like to go down there, and I usually ask my husband to go down, and how often that happens? Oh, once every 6 months. The idea of me giving that person a psychiatric diagnosis is nuts. mean, use expression. It's not reaching some sort of threshold. So the idea of some dysfunction, I think it does make sense, but, and this is, again, I may tell too many clinical stories. I got a referral from a person from a fairly high-level company in New York City saying, I'm worried, this is the manager saying, this person has been talking about some experiences to other people in the company that are kind of freaking them out. So he comes and visits me, looks normal, has a reasonable social relationship, a little socially isolated, but well within the range of normality. And then he's kind of uncomfortable and says, well, I guess I better tell you something, doctor. And he goes to the story that he has, since early adulthood, had a morning ritual in which he has to go out onto, he lives in an apartment building, out onto his patio, and he has to hold his arms in a very sort of special place out. And he then receives vibrations from a water tank across the street, which is bouncing off some kind of symbolic radiation from one of the moons of Jupiter, in which an extraterrestrial intelligence is communicating with him directly. And I'm a little astounded. He's perfectly normal. I ask about other hallucinations, other psychotic symptoms. He's not paranoid. It's a very isolated kind of psychotic belief. And my profound advice to him is, don't talk about this to your family or neighbors. If you ever get upset about it, here's my number. We could have some medicines that would treat you, but they might have side effects. But he seemed to be doing okay. But I was not willing to call that person unaffected, because unlike the snake phobia, which is very common, or spider phobia, something more serious was going on. So I don't see the DSM as making a strong metaphysical claim. Certainly the field of psychiatry has always been worried about its legitimacy. So when I was in medical school, I got cornered when people began to know that I was going into psychiatry and got one of those, what's a smart boy like you going into a field like that? Or questions like, you're not a real doctor, are you? So there is a defensiveness, and I think a rationale of setting up some boundaries, but I don't find it particularly excessive in that definition. So that would be my response.
Great, thank you. That's really, really informative. Thank you.
We have quite many questions, so maybe
so
we
you
can...
might want to edit them so we don't get too far behind. So maybe another
Well,
few minutes.
I was thinking about, so maybe, so the one by Amir and the other one here in the chat, maybe I can read them together. I mean, the
Okay.
two of them together. So the first is, would you expand your comment on borderline personality disorder to other personality disorders? If not, what makes them different?
Oh, I was only, so borderline personality disorder is a very specific genealogy. It came out of borderline schizophrenia, out of a particular, only in the United States did people get interested, Hock and Palatin. So historically, it was a little, small road from a small road from a small road. So it came out in a very unusual way. So it'd be less likely to be historically reproducible. I didn't mean much more than that. Other features that are more common, antisocial personality, I mean, anybody who reads through history, there are people like that. I mean, think about Caligula or anybody else you want who just have no compunctions, can be quite cruel. So I think that's likely to be more stable. It's not more profound than that. So not much more to say.
The next question, because we're talking about ontology here, the next question is, do you have any observations of how diseases pass into each other, like a cycle? After a lasting remission, something comes to replace them, question mark. For example, I had a patient with schizophrenia who responded well, but then developed severe asthma, something completely atypical, etc.
No, I don't have a very good response to that. So certainly, I mean, I do empirical studies of follow-ups. Most psychiatric diagnoses are relatively stable, the exception being manic depressive illness, which by its nature switches poles. But that's not unique to psychiatry. It occurs in lots of rest of medicine. So are disorders unrelated to one another? No, absolutely not. Psychiatrists share some genes, share some environments, but so do autoimmune diseases, so do cancers. So they're not single entities in and of themselves. They're kind of complex, evolving features. That'd be a very brief reaction.
Maybe one last one, and then we move to the next topic. So the question from Matthew was, I was wondering if you might be able to speak to the role of pharmacological models in the generation reinforcement of psychiatric categories. I'm thinking especially about the somewhat recent NMDAR model of schizophrenia, for example.
Well, I would rather talk about Don Klein and his concept of pharmacologic dissection. So that has a long history. Don Klein had two very good empirical examples. Don was working in the 1950s at Hillside Hospital, where it was run by psychoanalysts and didn't care what he did with drugs. So he was doing these huge experiments, taking 100 cases of schizophrenia and putting them on imipramine, putting them on thorazine, putting them on antidepressants. And he found that there was a small group of patients diagnosed with depression who the nurses said came up to the desk 5 times a day complaining that they were dying, and they never were. And when he put them on low doses of imipramine, those patients stopped complaining. And that was the discovery of modern panic disorder, which is responsive to low doses of imipramine. So Don got the idea that you can use drugs to develop diagnoses. And then about 5 years later, when the MAOIs and the classic first generation antidepressants came, there's a concept of atypical depression, which when you get depressed, you sleep more, you eat more, you slow down, as opposed to sleeping less and eating less. And lo and behold, showed that MAOI inhibitors specifically were superior to the tricyclic antidepressants in that area. So we do have a tradition. And remember, the discovery about the difference in type 1 and type 2 insulin was a result of their response to insulin injections. So we have a history within medicine in general and psychiatry of sometimes using diagnostic probes that open up the avenues of possible etiology. The NMDA stuff, that's much more complicated, and I have a less deep understanding. But in principle, it's played a role in our history. And I must say that, what's the right word? In the jocular humor of psychiatry, you see patients with bipolar illness where you might end up 10 years later saying that person had a lithium deficiency disorder, because you give them lithium and they just get completely better. They don't have remissions, they don't have side effects, not very often, but that's in a more jocular vein.
Okay, thank you very much. I think we can maybe move to the next topic and maybe keep the two remaining questions for later, if possible.
Okay. So the next question, which I think is equally, if not more profound in the more scientific part of psychiatry, is how do you deal with the diversity of putative risk factors for this disorder? So I usually start with, if you took, as I did, 3 or 4 years of leading psychiatry and abnormal psychology journals and try to write the level of science that those papers are addressing, you get a list that is more diverse than any other department in any modern university would evaluate. So you will get basic neurochemical theories. You will get issues about small neuronal networks. You will get information more of systems neuroscience, fMRI, big tracks. You will also get anatomical differences. You will then go into multiple areas of psychology, from personality to fears and anxiety. And then you will talk about family systems. And then you will talk about social influences. And you will talk about cultural influences, for example, on substance abuse, which are very strong. And then you'll talk about a role of religion and religious processes. So you're going from atomic processes to human culture, and they all are empirically relevant. So how the hell do you do a science, with that amount of diversity? It's completely confusing. I am a fan of Sandra Mitchell's concept of integrative pluralism. Sandra also comes from Pitt, like Jim does. I've read a great deal. I've tried to apply. Ken Schaffner has contributed with his concepts of patchy reductionism. But basically, the theme is something as follows. Inevitably, in a psychiatric research career, you're taking a fairly small part of the big picture. And there is an unfortunate tendency among scientists to think that the part that they're investigating is by far the most important part in the whole feature, and that everybody else should be paying attention to where they're doing, and that their job of trying to find links between what they're doing and somebody else doing, that's for somebody else to do. And if you're using a metaphor and you have a little plot of land and you take a shovel and you just take a yard square, and for 25 or 30 years you just dig down and down and down, looking at one topic, down and down. And our scientific funding system supports that sort of hyper-specialization. The dilemma is that if everybody's doing that, you get this balkanized kind of literature. So the integrative part of pluralism is something as simple as follows. Every once in a while, every 3 years, every 5 years, you got to climb out of your hole. You need to look around at the boundary disciplines and realize that part of your scientific contribution has to be knitting together some of the themes in this multi-level process that predisposes to psychiatric disorder, because otherwise we're going to end up with a series of non-integrated balkanized areas. I think that's the overall major point. What else do I want to say? So this brings up the issues about reductionism. Reductionism is a powerful tool. In a lot of my work, certainly molecular genetics is a reductionist model, neurochemistry is a reductionist model. If we're likely going to develop new treatments, new pharmacologic treatments, that will be from reductionist tools. We are now taking, patches of your skin from people with schizophrenia, and we are taking those skin cells, putting them in a dish, transforming into neurons, and then putting them in this sort of swirling little thing and growing them up into tiny little brains that we look at, and then we can put multiple brains together, so that's as reductionist as possible, and that's fantastic. But if the only thing you do is reductionist models, and you don't integrate and don't realize that at the end of the day, your responsibility is to take that reduction and bring it back so that at some point I might sit with my patient and say, okay, this is how we understand your brain being dysfunctional. I remember watching when I was a medical student, having a young man coming in with the first onset of diabetes, and he had heard all these instructions. You do this, you wash your feet, you get sick, you take more insulin, and never understood why. And a well-experienced clinician on a pad of paper drew out for him in simple ways, insulin balance, diet, and his eyes kind of lit up of him being able to understand, oh, this is what's the matter with me. That's why when I do this, if I exercise more, if I get sick, I want psychiatry to be able to do that. I want us to be able to say, this is what happens when you get frightened. This is what occurs when your voices get worse. This is why when that happens, you might want to call your doctor, because our understanding about how this medicine works is it's going to reduce the voices. When you've got a depressive predisposition and you have a bad event and those sad negative thoughts are arising, here's what's happening in your brain and mind, and here are the kinds of things that you want to respond to that. So that has to be the end goal. It's not all about getting papers in Nature, getting in Nature and Science, getting awards. It's also understanding the science, integrating it, and bringing it back to our patients. I think that's mostly what I wanted to say. I think that certainly does relate to the idea of top-down causation. And if you've read that paper, I can't argue more powerfully than the vignettes that I collected there. But there are occasions in psychotherapy, these sort of moments of reflection when you say something back and you can just sort of see the person's face thinking, and then they start making connections about the habits they've done. And it's quite thrilling when it occurs. Hours of psychotherapy go on with nothing like that. But that is a top-down intervention. We are minded creatures. We are brained and we are minded. And ideal psychiatric intervention, and again, I say this, I realize I'm rather on, philosophers think a lot about the mind-body problem. Active psychiatrists live it. So if you're caring for people who are on medication, schizophrenia, mood, bipolar disorder, major depression, panic disorder, and you're sitting in a supportive psychotherapy session, you're going back and forth. Is the dose too much? How do I help about psychology? And you're sort of jumping back and forth across this mind-body divide, trying to figure out how to integrate. We really could get a lot better in doing that. But that's a sort of central issue in our science. Only moderately coherent. I think I'll stop there.
Great, thank you. So questions, objections, comments about this? Yeah, Diogo, yeah.
Hello. So I'm talking from Lisbon, from Portugal, and I'm psychiatry and also I work in philosophy of science and psychiatry. And I had it's a pleasure to listen to you first of all because I've read a lot of things from you, and you're one of those people that psychiatrists should read regarding these critical issues. And my two questions. First of all, I would like to hear your opinion regarding diagnosis, and you touched a point that is very important that, as I understood, it's difficult to have biological markers to start to diagnose or to use as tools to diagnose a psychiatric patient. And I would like to ask you, what's your opinion about the distress and disability markers that were launched mostly and after a very important conceptual analysis by Spitzer and all the group, and that are being, from my point of view, undervalued in the last classifications, namely DSM, and namely in the general definition of mental disorder, because in the first definition launched by Spitzer, distress and disability were, as I understood, the main concepts that were used to separate disordered person from a non-disordered person. And in the last definition in the DSM-5, you have that the most important issue is eventual psychiatric or psychological dysfunction, and that distress and disability may be present. Probably, of course, you have read that. That's the first issue. The second issue is...
Why don't we let's stop there
Okay.
and allow me to answer that question.
Okay, yeah.
In DSM-5, the organizers, David Kupfer in particular, had the idea that DSM-5 was going to be revolutionary because we were going to move from descriptive to biological markers. That was a highly unrealistic estimate. And of course, it didn't work because the science hasn't progressed. It's not that we wouldn't wish to have them, but so far the markers that we've developed have been very nonspecific. There may be a new generation, including polygenic risk scores, that will be there. And the evolution that was going to occur, people, I think, develop unrealistic ideas that we would throw away our diagnostic criteria and we're just going to have a panel of lab tests. If you look historically, and the area that I've analyzed is autoimmune diseases. The first operationalized criteria actually were for rheumatoid arthritis in 1943, years before psychiatry. You follow those over time, what happens is, as they began to get these biomarkers, they added them to the clinical criteria. So what happened is initially it was joint swelling, joint pain, these sort of factors, and then they had the rheumatoid factor. Then they developed anti-nuclear antibody. And so it was an organic progression, and you did that because the addition of the biological markers improved sensitivity and specificity. So what the DSM needs to find, and we haven't found data there, where if we were to take our current symptomatic diagnoses and add biological markers, we actually improve the performance overall. And we're all wishing for that, but we're not there yet. So I don't see this as a conceptually difficult problem. It would be lovely to have things like the dexamethasone suppression test that I grew up with. It doesn't work because of the non-specificity. So I think that would be my major sense. The debate, I think I've already touched on this. I tend to favor the idea that diagnoses should carry with them some disability or suffering. You could see by that last, psychotic disorder case, or certainly people with antisocial personality, who have no sense of suffering, that to lock that in, that you always have to demonstrate that might be seen as being too severe. So I think the DSM is sort of a not great compromise for that sort of struggle, would be my comment. So that would be my response.
Okay. And the last, thank you. And the last question would be, so you talked about the realism, and I have been working in that, the philosophy of science models in psychiatry. I would like to know what you think about critical realism in psychiatry, and for instance, the critical realism that was launched by Roy Bacher, Roy Basker.
I'm afraid I'm not familiar with the work.
Okay, but critical realism in general, what do you think of it in psychiatry?
I'm afraid I'm not familiar with the term, so I can't really comment.
Okay, so it's a form of ontological realism and some kind of epistemological relativism. So you accept the real ontological realism, that there's a reality beyond you and beyond your science, but that there are several ways to reach it, and Roy Basker, he launches a work that he tries to combine several models or several ways of explaining things, and in epistemology. So it's a kind of trying to combine the several methods epistemologically, and try to have a big picture of the reality. So it's
why don't you send me a reference or two to his work, and I'll try to read it.
I will.
Okay, thank you.
Great, thank you.
Okay, thanks for this. Let's try to aim, if possible, at shorter interventions. Otherwise, we'll really lack time for other questions and comments. So maybe very quickly, Amlan, and then we might have to move to the next. Ken, do you think you will cover 3 topics in total or 5 in total?
Well, I've got probably 2 more.
Okay, 2 more. This is just for organization's sake. Okay, so maybe Amlan, and then we'll move to the next topic.
Professor Kendler, can you hear me?
I can.
Thanks a lot for this talk. Thanks, Thomas, for organizing. I'm a grad student at the University of Cambridge's Department of History and Philosophy of Science. This topic of conversation is quite relevant to my work because I'm looking at top-down and bottom-up approaches of defining Alzheimer's disease. As you may know already, that the NIA and AA have released the ATN framework, which makes it possible to diagnose Alzheimer's disease in patients presenting with beta amyloid or tau without the need for any dysfunction or a syndromal component to the diagnosis. I was wondering what you think about that kind of reductionist approach to diagnosis, and what level of a supposed causal chain of disease should a disease definition or diagnosis track?
It's a very interesting question. I'm not sure I have many original thoughts to say. Clearly, we're quite comfortable by treating hypertension, which doesn't produce any particular symptoms for long periods of time because of its preventative effect on future outcomes. That's well established. Psychiatry's main approach to this was actually in the DSM-5, in the consideration by Will Carpenter and the psychotic disorder group on a sort of pre-psychotic or psychotic proneness diagnosis that they decided to pull and not forward. And they did that for two reasons. One is that the empirical evidence of the prediction of what they called conversion, it's an odd term, but it's usually these are people 16, 17, 18. There's several different diagnoses, including soft psychotic symptoms, anxiety, change in social functioning, odd ideas, but clearly not psychotic. And that the follow-up studies were showing only 25 or 30% of such people went on to a psychotic state, mostly schizophrenia, but also bipolar illness. But also the concern that even though it was off-label, people would begin to take such individuals, and if we use the term pre-schizophrenia and treat them with antipsychotic drugs, which had not been shown and which are potentially toxic, and therefore they felt that in a public health sense, the balance of this was negative. So I'm not expert enough in the areas of Alzheimer's to comment about how you weigh that. How much stigma there is involved to being told that you have Alzheimer's on the basis purely of those tests. But I think those are the issues, and they're weighty ones. It's not something that I think I can comment on more deeply.
Thank you. So perhaps we could move to the next question, Ken?
Okay, so this is going to be a short one, and then the last is going to be much more about a review. So DSM has many positive features, but it's had some strikingly negative impacts on our field. The best way I can tell the story is when I was doing clinical rounds, and we were seeing a patient that clearly had major depression, and the resident, relatively well-trained and bright, I said, well, can you describe the case to me? And what in this case is she iterated the 5 DSM criteria that the person met. And I said, well, what else did you learn? And she sort of looked up at me and said, well, what else is there to ask about? That was kind of a smack between the eyes. So what is the problem? We are in a time when healthcare dollars are getting watched. Psychiatrists are getting shorter and shorter med-oriented approaches. Checklists are beginning to dominate. And the perverse idea, and I really mean perverse because it would not have occurred to any of the developers of DSM, that a series of convenient indicators that for pragmatic reasons can give you the probability of having a diagnosis would somehow replace what is actually a detailed evaluation would arise. So I wrote an essay on this and came up with not such great terms, but I went back some to the physics literature about constitutive versus indexical kinds of comments. So, constitutive, I think Bridgman, right, in physics, sort of, there used to be, there is no longer, a platinum iridium bar sitting in the basement of some big building in Paris that is or was the meter. And the meter was nothing more than that. It defined everything you wanted to know about it. And that people getting trained superficially in the DSM were treating it like it was constitutive. And that has consequences. First, the diagnosis can never be an error. And that having depression is nothing more than meeting the DSM criteria, in that having a length of a meter is nothing more than having a length that approximates that a platinum iridium bar. It's a malignant trend, and it closes off understanding the rich phenomenology. For example, derealization is a common symptom in major depression. It goes something as follows. Doc, the sleeplessness is really hard. I'm just full of those sad thoughts. I think I'm not good. I may be bad to my kids. But the worst thing is, I don't recognize this world. My world was full of sunlight and hugging my kids and drinking a cup of coffee and kissing my wife. And that's gone. It's just all dead. I don't know what I'm doing. I just can't stand it. Right? So that's a kind of profound anhedonic state, which when a person starts talking about that, you don't need the DSM criteria. I mean, it is these deep felt consequences that young psychiatrists, you ask him about it, it's not in the DSM criteria, I don't know that. You got the profound anhedonia, right? This feeling, again, I tell clinical stories because that's how I make sense out of it. A 58-year-old depressed woman who kept resisting her children's push to come in for treatment. And she got to babysit her young granddaughter, half a day a week. And she said, Doc, my granddaughter came, that little child, she ran into my arms and I hugged her and I felt nothing. It was cold. It was inside. Something's really broken in me. I really need treatment. Okay. That's the feature of this profound anhedonia. So those are the parts that we are missing when we only focus on the DSM criteria. So what indexical is a sense that there is an underlying thing there that we don't define very well. We're still working on it and have been for 100 of years. We call major depression. And we get a convenient series of signs and symptoms that on average do a pretty good job of identifying it. But for an indexical area, the idea that when you complete those symptoms, that you've completely understood or valued the patient is clearly incorrect. And so I'm on this kind of little campaign, and I did talk about that. I got invited to the directors of residencies of psychiatric programs in the US to say, look, we're really in trouble. You're turning out people who think that this one dimension of DSM criteria is all there is to psychopathology. That's really a problem, and we need to overall fix it. So that's a sort of short thing that I feel pretty adamant about. And it's a bloody side effect because operationalized criteria improve reliability. We know that. It's sort of, it reduces the stretch, but it has this reverse sense of becoming fixed. One further thing. The problem with only using DSM criteria is that when you develop a big epidemiologic study, or I go out and want to study 10,000 patients with major depression in Korea, like I'm now doing, what does the granting agency want? Oh, they just want the DSM criteria, just those 9 criteria. You don't want to spend any more money asking those other things. No, I can't do that. You're putting me in a box because this is one concept of depression. I want to have the ability to test other ones. Maybe there's going to be some subgroup where the genetics are going to be different among different symptoms. So I want to pump that up. But the whole pressure is only to use those criteria to get into this circle of not being able to collect data that permits you to evaluate it. So the constitutive theory is malignant clinically, and it is malignant from a research perspective.
Very interesting. Any questions, comments? One very quick question perhaps is, how do you try to have an impact on the training of psychiatrists? Because one thing you just said is really related to the training. So how do you do that if you do that?
Well, the goal is that their teachers need to say, this is a useful vocabulary. You need to put it in your charts. You're probably going to be asked about it on the boards. That's how we do our billing. But to make you think that is anything like a careful psychiatric evaluation is false. And if you want to be a good psychiatrist and understand in deeper ways the experiences of your patients, you got to ask a lot more questions than just the DSM criteria. And you have to say that often and repetitively.
I see. Yeah. There's a question from the Bodo team room.
Hello, can you hear me okay?
Yes.
Great. So thank you very much for the talk. I just had a question kind of following up or digging it a bit on the DSM, or I mean, since you've been focusing a lot on DSM and the kind of rigidity within it, I guess I wonder if you could comment a bit on some of the other diagnostic, I guess, attempts that have been made, like the RDoC or the HiTOP, and whether you feel these have been useful advances in a sense beyond the DSM or not.
Well, a complex question. First, RDoC is not a diagnostic system and never claimed to be. It attempts to evaluate what we might describe as intermediate phenotypes that sit mostly in neuropsychological space underneath the symptoms. HiTOP is very factor analytic oriented. I am very historically oriented. And I think that part of one of the strengths of current psychiatry and its syndromes is we have long histories of those. And so if you were to put up against me a factor analysis, which is often based on mild outpatient, mildly affected college students, and I don't mean to take a swipe at psychologists, but that are the samples that they usually look at, versus to go into the more critically clinically ill patients, which used to be asylum-based practice, I would choose the latter every time as being a richer, better index of the true phenomenology. So I'm not a particular fan of HiTOP. Also, HiTOP is anti-thresholds and dichotomies, and they see the world as Gaussian distributions. And that's not how medicine often works. You can take a bone and give it pressure and it'll hurt a little bit. And then at one point, the bone will break and you have a disorder. The example that I often use is you get a heavy snow on a slick surface and you put a thermometer in that and the thermometer will gradually get higher and then you'll have an avalanche. You have someone who is softly drifting into a psychosis. They're beginning to think about difficulties. And this has been described, in usually 24, 48 hours, the psychosis manifests and they begin to make sense out of the world. The delusions form. Those are important state changes. So that doesn't mean that there are some things. Generalized anxiety disorder, you don't have that. It's mild. But some of the critical psychiatric disorders really do have dichotomies. So I'm less a person who wants to always see the world in Gaussian distributions.
Thanks.
We have a question in the chat coming from Elodie, who says, I'm wondering whether you think that clinical phenomenology as a subfield of philosophy or psychiatry can be useful for psychiatry to refine the description of symptoms and clinical pictures, the knowledge by psychiatrists, and or the formulation of clinical criteria.
I'm chuckling. I've had a 40-year conversation with Joseph Parnas on this topic. He keeps trying to get me read Heidegger and Husserl and Merleau-Ponty. And I've tried 3 or 4 times. It's like running into a swamp for me. I see a difference between high quality descriptive psychiatry, the kind they're full of 19th and 20th century examples, and phenomenology. And among the phenomenologists, there are those who use a language that is, I would say, purposefully opaque for the sort of subgroup of them. This sort of thoroughness and other kind of topics that if they were trying to write for the more common person is obscure. But there are some phenomenologists who write clearly. And in those cases, I'm all with them. That is, they can explain concepts like the differences in anhedonia. So I divide those. They're sort of the professional philosopher types who are writing for philosophical audiences with their own terminology, and those that are trying to explicate the meaningful features of descriptive psychiatry in ways that people working in the mental health field can appreciate. And those are two different groups, in my view. And one has quite a bit to contribute. And I do read a fair amount in that area. Plus, but I also read a lot of descriptive psychiatry and write about it. So
I forgot to mention that Elodie was mentioning Daniel Radcliffe on depression, in particular the book Experiences of
yes.
Depression.
Yeah, that's a great book. I've read that 3 or 4 times. I mean, what he did is he got all these questions. He did some sort of website, and he built his philosophical structures on a lot of those quotations. That is a very good approach. Some of these are kind of ex cathedra, these complex subjective experiences, which I have little patience for. I mean, this is a whole issue in reading philosophy. Some philosophers write for other philosophers. And I guess I will take a digression here for a minute since we're so short of time. I've had a fair amount of contact with philosophers of psychiatry, and they run into 2 groups. This is a story that Jim has heard before. I attended a meeting of mostly young European philosophers of psychiatry. I sat there for 90 minutes. There were 15 major misstatements about the field, of misunderstandings. And at the end of the meeting, I ran up excitedly to a couple of the speakers and said, you said this, but this is really this. I'm happy to send you references. And they weren't interested in talking to me. I was stunned. It's a little bit like the meeting, this philosophy meeting. There seemed to be a group of people who want a little world. They take mind and brain and they draw arrows back and forth in all which way, and they grab one case study and then they'll dig that to death. But don't ever look up. They don't go talk to clinical psychiatrists who know things. It's mind-boggling to me. So at least from my view, and of course they don't give a damn about talking to the field of psychiatry. They have this little internal dialogue. I think that's kind of a waste. If you're going to do this field, either read a lot about it, find a collaborator, and yes, you can write for your philosophical colleagues, but also write things that are communicable here. Now, again, I'm a quick example. I know Katie Taub very well. She came out of the Pittsburgh School, and she had her mid-tenure evaluation at Columbia. And what they told her is, stop publishing with all these psychiatrists in psychiatric journals. You won't get tenure when you do that. I mean, my mind just sort of sizzled. What kind of field are you guys developing if you want them to just talk amongst your own other little clique and not communicate? So you can tell that I get a little agitated about that topic.
But that's a big, nice description of what is usually going on within philosophy. So, okay, so with that, maybe we can move to the next topic, which will be, I guess, the last topic. We have about 5 minutes, so I don't know. Yeah, let's try to do it.
Okay, so what I was trying, the last topic was, how do you actually practice psychiatric nosology in DSM? DSM is a whipping boy, whipping girl, whipping neutral pronoun for many people. Everybody likes to criticize it. It has a quite hard task. Science develops, and you would wish, so for example, one model of scientific consensus are the committees that used to work well at the US CDC, who would get topics like double-blind controlled trials of a certain cancer agent. And they would simply review that literature. They often would be aided by statisticians. They do a meta-analysis between them, and they talk about, different dosing and different subgroups and ethnicities, but their entire discussion about approval would focus on that one issue, which is efficacy. That's simple. Now, we're trying, let's say you put in a proposal to say, I want to change the diagnostic criteria for depression. I want to add this item. I want to add that item. I want to make sure that they have to have 4 weeks of symptoms and not 2 weeks. And they propose it to the DSM. Now, in the early days, when I started in DSM-3R, there was no organizational structure to do that. You have these group of almost all older men. There's a few older women in there. And they would pontificate. This was sort of what was an old idea of an expert consensus. In the 1980s and 90s, expert consensus was regarded by the medical informatics people as being the ultimate source of truth, now it's close to the bottom. Because, of course, what happens in those is some old guy says, well, I saw this lady 2 weeks ago, and I did X and Y, and she got better, because, of course, this is a good thing. So they start giving their own idiosyncratic approaches. When we got into DSM-5 and on the steering committee, what I tried to do is to develop a hierarchy of specific validators and then get the proposers to summarize the literature across validators. Now, that's way different than what occurs in the CDC, where you've got a single thing efficacy, because we've got so many dimensions. So we have, childhood correlates, personality, MRI studies, future course of illness, a reaction to medication, genetics, psychotherapy responsiveness. And so you get these scores of the original diagnosis and the altered diagnosis, the different, and trying to collect that data and then coming up with a qualitative decision about what makes it better or not is very hard. And often the data that's produced is fairly skimpy. So then there is the question, how do you balance the need not to have a frozen system versus having something that is overall flexible? I think a very good example was the last recent real major decision in DSM was of chronic bereavement. Clinicians has known about that for a long time. Clinically, I'm not going to have much time here. These are folks, they don't have depression. This is a woman lost a child in an automobile accident. 3 years later, she's spending half a day at the graveyard. The other, hour or two in the bedroom of the young daughter that's treated as a shrine. Her husband's ready to divorce her. Her kids don't get any attention. She's constantly grieving, and you try to say something about her, and she says, I'm just grieving my child. How dare you think I have a potential problem here? It involved bringing groups together, a broad consensus, trying to get the field to work together, getting it validated in a range of areas, and then how do you develop a threshold? Really hard. And the general sense was, we've got a real suffering group of people, but let's move the threshold out. People said, oh, it should only go on for 6 months. No, we can't do that. Maybe once we have 5 years of experience, we can tuck that back in. We had lots of arguments back and forth. We decided to set it at a year. And the threshold was such that we were only going to identify like 1 out of 200 or 300 people in the country, because we wanted it severe and didn't want to get accused of sort of normalizing, developing a broader reach of psychiatry for normative issues. I realize I'm going too fast, but the psychiatric world is very sensitive to the idea of taking what is normal grief. And we decided to make this narrow for people who are undoubtedly suffering in the condition. So doing DSM work is really challenging and doing it well. I think we're about at time. So we could take 1 or 2 questions and then I think I'm done.
Thank you. It's impressive. You managed to say in 4 minutes so much. So I hope there can be maybe 1 or 2 questions and then we can close. I know some people have to leave. I understand that, but maybe we can take 4 minutes, 3-4 minutes. So any questions, comments about what Professor Kendler just said? Yes, again from the classroom in Bordeaux.
Hi, Ken. That was a really fascinating talk the whole way through, especially for not being a talk, apparently. But based on what you've been talking about, that last case about chronic bereavement, the earlier case about the depression of the lady saying, I felt nothing when I embraced my granddaughter, and linking that to the whole question of the bottom-up, top-down causation. Could you say something maybe about a kind of the intersectionality of the 2 approaches? I mean, in the sense where pharmaceutical treatments sort of alter perception of what is coming in top-down, and how do you see that way of it? So we take a pharmaceutical and it changes perception so that anything that is coming in top-down, how we processes is altered. How do you
Oh,
see
that's
that?
a really complex question.
2 minutes.
I don't completely agree when you say alters perceptions. So it's been much more in depression than in psychosis. You have people, you start them on a drug, 2 weeks later, a little bit better, and they walk in 4 weeks later and they go, I saw the sun shining this morning. It looks so great. Oh my God, I really feel like these feelings are coming back. I don't see that as a drug effect. I suppose, is that they are describing a return of the psychological functions that they've had before. Now, a lot of people, not everybody gets better like that. I think that's not the same as how antipsychotic drugs work. That's complicated. Antipsychotic drugs, some of them have just a sedating, making you sort of stupid and amotivational, like Thorazine, which is very sedating. If you get somebody who's very agitated and you don't want nurses to get hurt, you might give them that initially. But one of the goals in antipsychotic is to try to taper it down so you've preserved as much of the kind of natural interest and enthusiasm, but the edge is off the voices. When they get, you're doing better when someone says, I had a fight at work, I was really upset, I got on the bus, but the people, and this is a person who would, when the psychosis starts, they get on public transport and everybody is saying nasty things about them, or they're sniffling or blowing their nose because they're emitting a terrible smell. And they say, I thought about that, but I didn't let that happen. I really think the drugs are helping me. So I think it is a subtle mixture. A good psychopharmacologist can try to use the medications in a way that helps reverse the fundamental mental state without kind of covering in other areas. Not always possible, but that would be a goal. I'm not sure that's a great response to your question, but at least it raises some of the themes you're addressing.
Yeah, no, it is. You understood better than I worded it, what I meant by altering perception, like that kind of, yeah, thanks.
Yeah, I mean, if altering perception is returning some sense of optimism to the world, I'll take that for an antidepressant. I don't know, it's brain, it's mind, it's something else, but the patients feel better about that. And usually it lasts. Sometimes when you stop the medicine, it goes away again. So it may be a medication effect as well.
Okay, I think we should stop now because we're 5 minutes beyond what we had said. So I really want to thank you, Ken. That was wonderful. And the conversation format worked very well. I know probably it was very tiring for you, but for us, it was wonderful. So thank you very, very much. Thank you for everyone who attended, and especially to Jim Woodward. Thank you very much, Jim. And Ken, thank you so much. That was really, really useful and very, very nice. So thanks a lot.
I did enjoy myself, and thank you to the people who asked the number of good questions. So I'm going to go ahead, stop and have some lunch and recuperate. So.
Yes, please. Bye-bye, and thank you so much.
Bye, everybody.
Bye.